Okay, so I'll do a review here with you, but I'm not going to go over everything verbatim. Okay, just because some of it is fairly self-explanatory, and also want y'all to look some stuff up. Okay, this is also an assignment that's due for points, but we'll go over, as much as we can to, especially the areas that might give you some trouble, meaning the more difficult areas. Okay, what are the three main functions of the lymphatic system? Okay, that is, well, first of all, anytime you see a function in the notes, okay, that is a test question. Okay, so what are the three main functions of the lymphatic system? Edema reduction, fat absorption, and defense. Okay, edema is swelling. Okay, the purpose of the lymphatic vessels is to move fluid toward the heart, to help move fluid toward the heart, to help absorb some of the excess fluid that's in the interstitial space. Okay, plus with inside of the vessels, you're going to have these clusters of nodes, right? So you have a tube, and at some point you'll get a node, and then tube, and then all these nodes along the way. And inside of the nodes, you have a bunch of Pac-Mans, okay, lymphocytes and all that, and they are going to help you destroy antigens, okay? So that's one of the three functions of the lymphatic system is defense. Okay, common areas of clusters. The cervical, axillary, inguinal. Okay, there's a diagram that we went over on the right and left thoracic duct. Okay, so make sure you look at that. It had an anatomical man. Okay, we'll do our gingerbread man for now. Okay, and then it was like this part on the right side that was responsible for right lymphatic drainage and everything else in the body. Okay, had to do with left lymphatic drainage. Okay, so make sure you review that part. And then what duct they go into. Okay. All right. Okay, what organs are considered lymph organs and what are some of their protective functions? Okay, so you'll want to review like the spleen, thymus, and tonsils. Okay, and then what they help you do, the function of these, okay, as far as lymphatic organs. Okay, the immune system, what are the three lines of defense? Okay, well, I'll get you started with the first line.
Sorry, Dr. J.
Second line and third line. Yes.
Oh, am I muted? No. Okay. I was looking up the one about the right duct and left thoracic duct. Was that, I'm trying to find the correct diagram. I was trying to find that one. Was that one of the ones that we drew out, or I'm trying to?
No, it was just embedded somewhere within the notes, the PDF notes or the PowerPoint notes.
Because I had the one that was like the venous system and arterial system. And then it was like the lymph duct, lymph trunk, and then like shown the three lymph nodes. Is that the chart that you're kind of talking about? Sorry, I can start my video really fast if you want.
Okay, so the immune system, the 3 lines of defense. Okay, so there's first, second, third line. What are the AKAs for this? And then what does each one do to protect you? Okay, so first line is stuff you're born with, like your skin, saliva, the ability to cough and sneeze and vomit. Second line, you want the inflammation to block off, wall off and protect you. So it's a non-specific version of inflammation. And then the third line is the part where throughout your lifetime, you're going to continue to develop and mature your immune system to be able to resist disease. And this is where your T cells and your B cells and other white blood cells and all that come into play. Okay, we looked at your different, so from the bone marrow, okay, the bone marrow ultimately produces your blood, okay, and then there's a bunch of different routes that takes, right? Your red blood cells, your white blood cells. Okay, there was the myeloid, well, wouldn't look more like this. Okay, so when the stem cells are given a signal, okay, it's going to go in different directions. Myeloid is one route. Okay, lymphoid is another route. Okay, the myeloids are going to produce your platelets. Okay, I'm going to just use the letter here, so neutrophils, eosinophils, basophils. Okay, monocytes, and also your red blood cells, also known as your erythrocytes. Okay, and then the lymphoid, okay, they'll produce the T cells, the B cells, okay, natural killer cells, and a derivative of the B cells is the plasma cells. Okay, that comes from the lymphoid side. Okay, so obviously there's a lot of questions that you can get from just that, right? Knowing their myeloid and lymphoid routes. Okay.
So just just to clarify on that one too. So the, oh no, never mind. I'm thinking more humoral immunity. Never mind.
Okay. Okay, be able to define natural immunity and acquired immunity. Okay, that's just something to look up there. Okay, what cells are part of specific resistance in immunity? Okay, specific resistance is part of adaptive immunity. Okay, so we have specific, and then the other one is the memory. Okay, there's the memory part of your immunity. Okay, so the specific targets specific pathogens. Okay, and then the memory immune cells allows for the quick response to the pathogen. Okay, now at the time, I gave you all kind of a silly analogy where we named viruses number 1 through 200. Okay, and to oversimplify this, we said at birth, you have been exposed to 0 of the 200 viruses, and all the adults in the room have been exposed to about 150 of them throughout their lifetime. And the adults are hanging around the infant and kissing on it and, you know, all the stuff family does. And eventually, virus number 1 gets into the infant, and that's something in the rhinovirus family, let's say. So the child is symptomatic for a week or whatever, you know, typical cold stuff. Well, since they've never seen virus number 1 before, their body has to learn how to fight it. Okay, so at first they're symptomatic, and then once they get over the hump and they're fine and, you know, they go back to normal, now they have a specific resistance against virus number 1, and it's stored as memory. So if they see virus number 1 again, then immediately the specific pathogens will go and attack, because now it is stored in their immune memory. Okay, and so likely they won't show symptoms again, because it'll attack it before symptoms are allowed to even surface. Okay, so it obviously it has not seen number 2, 3, or 4 yet, and if the child does, they'll be symptomatic, and then they'll learn to fight it. So when they see it again, they'll be fine, and thus the dance continues throughout a lifetime. Okay, so that's part of the specific and memory of resistance. Okay, cell-mediated immunity versus antibody-mediated immunity. Okay, that's part of what we did with our longhand nodes. So cell-mediated is where you're dealing with the T cells. Okay, and antibody mediated is where you're dealing with the B cells, where you're activating the B cells. Okay, the B cells have these things on them called antibodies. Okay, and then they release them. Okay, they release them to go after the antigen. Okay, so if that is the antigen, then the antibodies are going to surround it and eventually destroy it. Okay, so that's antibody mediated. T cells don't have the antibodies, but what they do have is direct destruction or direct destruction via the chemicals. Okay, humoral immunity. So when you see the word humoral, okay, this basically means fluid. Okay, like remember the eye, you have the aqueous humor and the vitreous humor, or that's a derivative of the word humoral. Humoral immunity is in the blood, which you can look at that as a type of fluid, and it's also known as the antibody-mediated immunity. Okay, so humoral immunity and antibody-mediated immunity are AKAs of each other. Okay, the B cell development, that was part of our longhand notes where ultimately they come from the bone marrow. Okay, and then they're released into the bloodstream. And so they like to travel around in blood and your lymph and your lymphatic organs. Okay, the B cells like to, they can divide. So there's our division symbol. Okay, so they divide into plasma cells and B memory cells. Okay, the plasma cells release the antibodies. Okay, the B memory cells allow for that quick response. Okay, and here's the key. After the first exposure. Okay, after your first exposure. Okay, so allows a quick response to the same antigen. Okay, an immunoglobulin or an IG is an antibody or a type of antibody, right? It's a white-shaped protein. Okay, and then we can divide those into the 5 different immunoglobulins, or the classic ones, right? So the IgG, IgM, IgA, IgE, and IgD. Okay, that's also in order of most common to least common in the body. Okay, so know them, or that should say know the most common, or the most abundant to least abundant. Okay, and I just listed them there for you.
You had an acronym for that last time. What was that? I'm pretty sure you did, or that might have been, I thought you did.
I don't think I did. Maybe, yeah, I don't remember if we did or not. Not off the top of my head. Okay. Okay, and then know the function of each. Okay, so you'd have to write out, you know, do IgG and then what it does. Like, for example, IgG is the most abundant. It can cross the placenta barrier. It's typically the first responder to an antigen. Okay, so it's the major supply of the antigen antibody complex. Okay, an epitope is the unique part of the antigen. Okay, the unique part of the antigen, the antibody recognizes. Okay, an induced fit is that unique interaction. Okay, so if this is the antigen, okay, and there's your antibody, you know, you could tell just by looking at this that this would fit nicely into there. So that's an induced fit. Okay, they're highly specific interaction, and this allows for a specific bond between the antigen and the antibody. Okay, this one here, the neutralizing of antigens, precipitating antigens, activating complement, then precipitating antigens, and then facilitating phagocytosis. This is stuff we drew out. Okay. So when you neutralize an antigen, you want the, that's part of the antigen antibody complex, right, where there's an actual bond that takes place. Okay, and then this activates complement, right? So help comes in. Okay, and what allows for that is your signals, which is chemo, taxis, and inflammation. Okay, those are what sends out the radio signal, if you will, for things to come in. Okay, activating complement. So more white blood cells and antibodies and all that can come to the site. And then the third part there, the precipitating of antigens, has to do with numerous antibodies that will bind to the same antigen. Okay, so lots and lots of these guys will come in and bind to the antigen, and then that begins the phagocytosis process, right, where your big eaters come in. The macrophage, and it will engulf the antigen and the antibody. Okay, the antigen is broken off. If you remember our analogy, where you smash the cracker, you know, if you're given a saltine cracker, which is basically, you know, like a perfect square, and you smash it, okay, you're going to break it down into a bunch of pieces. Okay, so the antigen is phagocytized by lysosomes, so it's degraded, and then a piece of that antigen is carried to the surface. Okay, and this also activates your major histocompatibility complex and the antigen presenting cell. Okay, so the facilitating of phagocytosis destroys the antigen, but then also takes a piece of it to the surface. All right, and that is part of your MHC, right? Major histocompatibility complex, and that, in a nutshell, is what helps you determine you from not you. Okay, your own cells from not your cells. So, for example, if I took my kidney and put it into you, your body is going to know that's not your kidney. Okay. If you take a pathogen, if you take an antigen and put it inside of you, your body is going to know that that's not you, right? So it's going to attack it. Okay, so when that goes wrong, okay, when your major histocompatibility goes wrong, that's part of your autoimmune disease, right? Where healthy tissue is attacked by your own immune system. Normally that should not happen. Your own body should not attack itself. Okay, so when things are working normally with MHC, your body will scan itself. It will recognize you from not you. Okay, once the cell surface protein is present, okay, so what is the cell surface protein? Well, we mentioned it there. What happens? Okay, a signal is sent out, and what does a signal do, or what is recruited? Okay, so this gets into okay, so after the antigen is broken down, okay, then a piece of it is sent to the surface. So now we have the cell surface protein. All right, a signal is sent out. Okay, that's part of your chemotaxis, and it is going to bring in or recruit or activate T cells. Right, and there's the nucleus of the T cell. Okay, once the T cell comes in and recognizes the cell surface protein, it basically activates itself, and when that happens, it becomes cytotoxic. So now it's a cytotoxic T cell. Okay, and it's going to send out, and kind of look at it as drones of itself. Okay, so there's the little cytotoxic T cells, and it's going to go in and destroy that cell surface protein. Okay, this is also part of your cell-mediated immunity, right? Your cell surface protein, the cell-mediated immunity. Okay, so what is a cytokine? Okay, now we listed a bunch of those in our longhand notes. We listed a bunch of that, I think toward the end. Okay, so you have like your interferons, your interleukins. Okay, so basically they are proteins secreted proteins that signal. Okay, and then they come, like for example, an interleukin or your ILs, right? And you have interleukin number 1 through 35. And they all have a different function.
You're just kind of wanting us to remember the interleukins 1 through 4, correct? Because that's what I have in my longhand notes.
Well, yes, we only did some of them. Just because I thought that would be a lot to have to remember 35 different interleukins. We can go over 5 through 35 if you want.
No, it's fine.
I know, I'm just kidding, I know.
One thing I just wanted to clarify really fast, just going back to the B cells and the T cells, was that were B cells, I had that T cells are finding an antibody and spray chemicals on them. But then for some reason, I thought you said the B cells do that, but it's just the T cells mostly that deal with chemicals, right?
Correct, yep.
Okay.
So the B cells release the antibodies, the T cells release a chemical designed to kill the antigen.
Okay, perfect, thank you.
Okay, you're welcome. An interleukin is a type of cytokine. Okay, they also activate other parts of your immune system. Okay, so that's some of the things we wrote down toward the end of our longhand notes, right? So like interleukin 2, for example, allows so T cells and B cells communicate with each other. And the interleukin 2 is what helps stimulate the cell division of your T cells and B cells, right? So all the interleukins recruit and have a different function. Okay, your T cells ultimately come from the red marrow. Okay, when they start out, they are immature T cells. Okay, and then they migrate to the thymus. Okay, where they mature into T cells. So we'll say M for mature T cells because of thymosin. Okay, the hormone that's released from the thymus. Okay, from there, the T cells float around in your body. Okay, they're stored in lymphatic tissue, lymphatic organs like the nodes and the spleens. They are in the blood. Okay, so they mature once they leave the bone marrow and go to the thymus. Okay, the cytotoxic T cell. It's a cytotoxic T cell is a T cell and its ability to release these toxins, so therefore cytotoxic, and they release the lymphotoxin and the perforin. Okay, this is the stuff that, or earlier when I said chemicals, now this is more specific to that, the lymphotoxin and the perforin. The lymphotoxin is designed to destroy the DNA of the antigen, and the perforin is designed to create cell lyse. Okay, by punching holes, chemically punching holes into the pathogen's membrane, so perforating. So perforin is a derivative of perforate, right? So you're punching holes into the antigen. Okay, helper T cells release interleukin 2s. Okay, and that causes or stimulates cell division. Okay, you have your T cells and your B cells. A memory T cell remains, well, first of all, once you create them, okay, they remain dormant. Okay, until that antigen presents itself. Okay, and I emphasize that antigen because these are specific, right? So going back to our numbered virus analogy, if you've been exposed to virus number 1, and now you've created a resistance against it, and then down the road you're exposed to number 1 again, okay, it would be that antigen or that specific antigen. And then the memory cells that were dormant now become active, okay, and then they convert themselves into the cytotoxic T cells, and then the cytotoxic T cells does its job, okay, through the perforin and the lymphotoxin. Okay, define or what is a NK? NK is a natural killer cell. Okay, now there was a lot of things that we wrote down about natural killer cells. Okay, for example, they do not require to be activated in order to kill cells. Now, what that means is, okay, be careful with this word activation. Okay, so there's two types of activation, right? You have chemotaxis activation, and then you have receptor activation. Okay, they don't really use this chemotaxis version, they use their receptor version. Okay, and that's this one here, name the two different kinds of receptors that the natural killer cells have and their function. Okay, and there's the natural killer cell, and you have your activating receptor and your inhibiting receptor. And you, or your tissue, okay, your tissue of you is going to have, okay, a cell, a surface molecule that all cells have, okay, which is this one. That's your surface molecules that all cells have. And then you'll have the MHC class 1, okay, which is just a fancy way of saying self. So when a natural killer cell and its receptors go over your own tissue, because you have the MHC class 1, they will bind and it will inhibit the natural killer cell from doing its job, meaning it won't destroy the tissue. Okay, now obviously in a not you, okay, so I'm going to erase this, and okay, in a not you situation, when the activating receptor is activated, then it's going to release its perforin to destroy this tissue or the cell or the antigen or whatever it is, and just because it's not you, okay? So that is the two different receptors and their function.
So I got a couple of those wrong on the quiz I think I took because I got a little confused. So basically it's part of MHC and it doesn't need inflammation or chemotaxis to activate. It has the receptors that basically recognize on a cell if it's got MHC or not. That's kind of breaking it down into, I don't know.
Yes.
Okay. So basically just sees like MHC on a cell, and if it has it, then it says, okay, I won't kill it. But then if it doesn't have MHC, then that's when it goes into destroy mode, I guess.
Yes. Yes, no, you're right. That's right. That's right.
Okay, sorry, I got that wrong on the quiz. So okay, thank you.
Okay, you're welcome. Okay, what recruits natural killer cells? That would, okay, cytokines can recruit them. Okay, and I think I had a video on this as well that was under the module page that shows to like 3D animations how this stuff works as well. Okay, what is MHC? Well, that's major histocompatibility complex. Okay, we have 3 classes. Class 1, Class 2, and then Class 3, which is kind of in a category by itself because Class 1 and Class 2 are responsible for your HLA, okay, which stands for human leukocyte antigen. Okay, Class 3 is responsible for different or various immune proteins like complement. Okay, the AKA for MHC is the HLA, human leukocyte antigen, via the Class 1 and Class 2. All right, they come from, well, all 3 of them do. So Class 1, Class 2, and Class 3 come from chromosome number 6. Okay, so what does each class do? Okay, so I'm just gonna say this orally. You guys can get more specific with it later as you write it out. So Class 1, okay, is an HLA function, so human leukocyte antigen. It's found on your nucleated cells. Okay, it does present different protein fragments. Okay, so a protein fragment is a peptide at the surface of the cell, so you can recognize self from non-self. Okay, and that's what we drew up here earlier. Okay, so you can recognize self from not self. So healthy cells are ignored and foreign protein cells are attacked. Okay, because the foreign will not have your self marker on there, right? Your HLA marker. Okay, Class 2 is part of the antigen presenting cell, which helps with the self from not self. If the antigen presenting cell is not you, it alerts the immune system, which triggers the adaptive or specific immune response. And so your T cells will come in and destroy, and that is what we did up here. Okay, so that's part of Class 2. And then Class 3 is the activation of the various of other proteins like your complement and some cytokines. Okay, cytokines are your interleukins, your leukotrienes, and your interferons. Okay, so interleukin 1 will do things like tell the B cells to proliferate. It helps induce inflammation. It's what leads to a fever. Okay, it recruits macrophages and monocytes, activates natural killer cells. Okay, interleukin 2s activate your T cells and B cells and natural killer cells. And interleukin 3s activate the T helper cells, the mast cells. Okay, and mast cells also are part of histamine. Okay, they also release histamines. Okay, and histamines can be in your allergic response family of things. Okay, and interleukin 4s activate the CD4 cells, mast cells, macrophages, B cells, IgEs, T cell proliferation. Okay, a common theme throughout the interleukins is to increase inflammation and bring in phagocytes. Okay, so when in doubt with your interleukins, like if you're like, I just don't remember, you start with their overall main function: increase inflammation, bring in a bunch of Pac-Mans to the site. Okay, your Pac-Mans are your phagocytic cells. Now we have a lot of different types of Pac-Mans: T cells, B cells, natural killer cells, mast cells, CD4s, right? All that stuff, other white blood cells, monocytes. Okay, leukotrienes, right? So leuko means white. Trienes means 3 double bonds. Okay, that's where they get the name from, leukotrienes. Okay, they're part of their function is to help with the inflammatory response. Okay, they activate neutrophils. Okay, their job is to also sustain the inflammatory response. Okay, they're also part of the allergic reactions. Okay, and if leukotrienes, as part of the allergic reactions, if they're taken too far with all the different things that they recruit, then you're going to have your classic anaphylaxis type stuff, such as decreased airflow, increased mucus production, okay, increased inflammatory cells and all that in the airway. All right, now the reason why I bring that up is because on one hand, our immune system is designed to create inflammation and do all these things. You know, you're symptomatic and you have a fever and mucus production and all of that. Okay. However, that can cross a line and the fever can be too high. The mucus production can be too much. The inflammation can just be taken too far. So to some degree, there's a fine line between just let your immune system do its job and we have to intervene. Okay, and obviously if this spins out of control, then you have to intervene. You know, for example, using an EpiPen. I don't see interferons in here, so let's add Okay, interferons. Well, first of all, it's a protein, okay, released by lymphocytes. Okay, it's activated because of an antigen or a pathogen, like a virus, for example. Okay, bacteria, parasite, tumor cells. Okay, anything in that family, you know, they can, it'll activate the interferons. Okay, they get their name because it interferes with the pathogen. It interferes with viral replication. Viruses need a host cell. A human is a pretty good host for a virus. The cells in the human are a good host for the viruses to replicate. So the interferons are designed to interfere with that process. Okay, the interferons activate natural killer cells and macrophages. Okay, the interferons are also responsible for the muscle aches and the fever that you can get. You know, I think we've all been sick at one point, flu-like symptoms and whatever. Likely that's the interferons at work doing their job. Okay, complement. An easy way of looking at complement, it's like bringing in backup, right? If you are alone trying to take down a really big bad guy, you're just going to need help. So you recruit other soldiers to come in and help you. Okay, so complement comes in and they work together to destroy the antigen. Okay, they're a type of protein that are inactive until activated by a chemical signal. Okay, the chemical signal is released once you have the actual binding. Okay, once it binds, then chemical signal is released, and then complement will come in to help. Okay, when you opsonize something or opsonization, okay, that marks the antigen for destruction. Okay, opsonization marks the antigen for destruction. Okay, with blood vessels, you know, there's going to be two parts to this. You've got the gross anatomy side, so that'll be lab, and there's really not much one can do for another on that one because it's raw memorization. You know, like where's the brachial artery, where's the median cubital vein, you know, stuff like that. So that's just raw memorization. All right, and we'll talk about that one later. But some other things that are more concept things is things like arteries they're more oxygenated. The blood is oxygenated in your artery, in the artery family, okay, capillaries, arteries, arterioles. And the veins are mostly deoxygenated, okay? Arteries travel away from the heart and veins travel toward the heart. Okay, so a good way is to visualize if you're a red blood cell traveling through these tubes, what tube are you draining into next? Okay, so in other words, on the lecture portion, there's no pictures. So you have to visualize where these tubes are. Okay, so for example, if you're a red blood cell and you're currently in the subclavian artery, what tube are you going to spill into or drain into next? Okay, so you're going to go from the subclavian artery to the axillary, and then eventually to the brachial. And you're moving away from the heart. Okay, if you're a vein, you have to visualize what tube you're going to drain into going toward the heart. Okay, so part of that is concept, but a large part of that is being able to visualize. So that's your gross anatomy and raw memorization. Okay, so on the lecture part, there are some questions that have to do with, you know, if you're a red blood cell, what tube are you draining into next? And where it does seem, and I'm just going off of you know, test questions that have graded in the past, it does seem that the student gets confused on the direction of blood flow. Okay, arteries away from the heart, veins toward the heart. Okay. Okay, your baroreceptors and chemoreceptors, those are, well, first of all, your baroreceptors have to do with
Sorry, Dr.
pressure.
James, just to clarify, so if you're asking the red blood cells, you would drain into the heart, meaning it would be the veins, correct?
No.
Sorry,
That's okay. No, so okay. So the artery and vein system they're basically just one long tube, right? And these tubes branch out everywhere in the body. Okay. So the heart, okay, once you leave the heart and you're moving away from the heart, that's the artery family, right? So as the blood is traveling through these tubes, okay, for example, if you're a red blood cell and you're currently in the femoral artery, what tube are you going to drain into next? Going off the direction of blood flow. Okay, well, the answer would be the popliteal artery, because the femoral artery is going down the leg, and eventually it's going to turn into the popliteal artery, which is behind the knee. Okay, if you're a red blood cell and you're inside the brachial artery, what blood vessel are you going to drain into next? Okay, so the brachial artery is going to give rise to the radial and ulnar artery. Okay, so that's what you would spill into next, because that's the tubes that come after the brachial artery. Okay, so so not necessarily a red blood cell flowing through the heart itself. It's a red blood cell traveling throughout the tubes in your body. Okay, let's do a vein, or give a vein example. Okay, if you are a red blood cell.
you had a couple, I'm so sorry, you had a couple of like diagrams that just kind of showed like the external iliac artery down to the femoral artery and all of that. So basically we should just memorize those charts exactly in like the order of which, like what direction they would go in.
Oh, absolutely. Yeah, and that's going to be that's important.
Okay.
That's going to be, yeah, very important.
Okay.
Okay. Now, if some of you go on to, let's just say, more advanced nursing techniques, where you're going to be doing central lines or, you know, there's surgeries and stuff that involve with going inside of arteries or veins. I mean, it's really important to know what's coming next. Okay, the direction of travel. So like a vein, for example, okay, if you're a red blood cell, inside the cephalic vein, what tube are you going to drain into next? Well, the cephalic vein is in your arm, okay, like it runs with the humerus, and it's on the more lateral side of the humerus. And the cephalic vein happens to drain into the subclavian vein, okay, because it's working its way toward the heart. And then the subclavian vein eventually drains into the superior vena cava, and then the superior vena cava goes into the right atrium. Okay, so that's the direction that red blood cell is traveling. Now, granted, there's millions of red blood cells in just one tiny little area. I'm just saying it that way so you can visualize, just try to visualize what this looks like as you're traveling from point A to point B. Okay, but that one is, to some degree that's kind of hard to review per se, because it's raw memorization. Like, it's something you have to sit down and visualize. And as you said, that chart that I have, that flow chart, that's a really good one, so that it tells you what tube is draining into next. Okay, and then the arteries, we start from the heart, and then the veins, you can start from the periphery. You can start from the hand and work your way to the heart, and start with your foot and work your way toward the heart, because veins flow toward the heart. Okay, so your baroreceptors have to do with pressure change. Okay, like for example, laying down to standing up is a pressure change, and your body should adapt to that. Your chemoreceptors are chemical changes to, like, CO2 and pH. Okay, pH has to do with your acidity and alkalinity. And those receptors are located in the aortic arch and the carotid sinus. Okay, and that's where the cardioregulatory centers are located. And then they're also located in the brainstem. Okay, review your blood flow through the heart, because you'll have to go back to your cardio to do that. So blood enters into the right atrium, spills into the right ventricle. The right ventricle ejects blood to the lungs. The lungs then eject blood to the left atrium, and that spills into the left ventricle, and then your left ventricle pumps blood to your body. Okay, now that's the quick version. But when blood is being ejected from the left ventricle, it goes into the ascending aorta, and then the ascending, and then the aortic arch, and then the descending, right? And then you have those three branches off of the aortic arch. And and there's an order to them. And then so that's why they call it the aortic arch, because of the fact that it does have, an arch to it. Okay, and then you have the brachiocephalic. Okay, the left common carotid, and then the left subclavian. Okay, laminar versus turbulent. Laminar flow is what you want or what's preferred, because that means the tube is nice and open and blood is traveling through the tube very nicely, basically uninterrupted. Whereas turbulent flow means that there's some sort of kink in the tube. And when that happens, the blood flow is disrupted and it kind of swishes back on itself, creating a sound. Okay. This can happen because of some sort of pathology, meaning turbulent flow can happen because of some sort of pathology, or you can do it on purpose through a blood pressure cuff. Okay, where you're squeezing down on the artery on purpose, kinking the tube on purpose. And when you squeeze the blood pressure cuff hard enough, you have completely disrupted blood flow. Okay, and as you release the pressure and blood is slowly introduced, kind of one drip at a time, if you will, and you keep going and keep releasing, eventually the tube will go back to its normal circumference and it'll go back to laminar flow. Okay, so turbulent flow can be because of a pathology, or you're doing it on purpose because, like with a blood pressure cuff, for example. And that's how we can measure a person's blood pressure. Okay, hemodynamics is simply how blood flows through our body in the artery system. Gravity and the pump itself, which is the heart, helps move blood through the tubes. Okay, movement also helps. And that's where the veins come in. Veins rely on muscle contraction and movement in order to help get blood flow back to the heart. And they have the one-way valves inside of the veins to help with that as well. Okay, so we went over some conditions: arteriosclerosis, atherosclerosis, thrombus, emboli, hypertension. Okay, make sure you review those or know the difference between them. Okay, we have short-term and long-term regulations of blood pressure. Okay, both are within homeostasis. They can spin out of control and create, hypertension. Okay, so the short, those were in our notes with short-term and long-term. Okay, one of them was the Renin-Angiotensin Aldosterone. Mechanism. Okay, and we I think we've done that several times. Okay, but the kidney releases the renin. And the liver releases the angiotensinogen that's converted into angiotensin 1 because of renin. Okay, angiotensin 1 is converted into angiotensin 2 because of the lungs and the ACE, so angiotensin converting enzyme. Angiotensin 2 is a powerful vasoconstrictor. So what you have done is you have taken a big open tube and made it smaller. When you have a really small tube like this, it takes more pressure to push fluid through a smaller tube, right? When the diameter is, it just takes more pressure. So the result is increase in blood pressure. So for that to happen, the original stimulus was a drop in blood pressure. So the goal is to increase it. Okay, the aldosterone comes from the adrenal gland, right? So it releases aldosterone. In the presence of aldosterone, you're going to keep sodium and therefore keep fluid. Okay, so when you keep fluid, you've just increased your blood volume. When you increase blood volume, that's going to increase blood pressure. Okay, when you increase blood volume, the one way you can look at it is you've just accumulated a lot of fluid. Fluid is heavy. Okay, I'm going to fill up a yoga ball, fill it with water, and have you push it around the yard. Like, it takes a lot of pressure to push a yoga ball that's filled with water versus a yoga ball that's not filled with water. Okay, so anytime you're retaining fluid, and the more fluid you're keeping, you know, water's heavy, fluid is heavy. So the more you have, it's just harder to push. So it increases the pressure. Now, this is still within homeostasis, right? So your body has its own ability to regulate its own blood pressure, right? You have an upper end of blood pressure and a lower end of blood pressure, and it's a fairly lenient range. So all this is still within homeostasis. Granted, it can spin out of control and you can create problems with this. Okay, but for right now, we're not really talking about pathology stuff. We're just talking about, you know, this is one mechanism how your body regulates blood pressure. Okay, there was a pulse diagram, how to identify pulse. So like where the carotid artery is, for example, the radial artery, dorsal pedis. Okay, make sure you know that diagram and the names of those arteries that you can palpate to assess someone's pulse. Okay, the respiratory system, we had anatomy parts that consist of the upper respiratory system. Okay, so that's about at the throat area and up is your upper respiratory, and about the throat system and down is your lower respiratory. Okay, and there was functions to all of them. So what's, like, for example, what's the function of the nasal cavity? Okay, what's the function of the epiglottis? Okay, what's the function of the trachea? Okay, be able to define ventilation and internal and external respiration. Okay, there was some, you know, that's in the notes. Okay, if you were an oxygen molecule, what order would you travel as you enter through the nose and to the lungs? Okay, so I'll get you started. All right, you'll breathe in through to the nose, and you'll go through the nasal concha, right? And those superior, middle, and inferior nasal concha are designed to increase surface area inside the nose. Okay, then you'll travel down through the pharynx and the larynx, and then eventually into the trachea the trachea bifurcates, right? So you have the right and left primary bronchi that divides into the secondary bronchi that divides into the tertiary bronchi that goes to the terminal ends where you find the alveoli. Okay, anytime we covered some of the diseases and disorders and stuff, just make sure you know them. For A and P, it's fairly minimal. Okay, when we get to patho, obviously we're going to get into a lot more detail of different respiratory problems. Okay, like for example, what is asthma? Okay, I think that was one of the things that we covered. All right, so there was gross anatomy parts to the respiratory system, be able to label that. That will mostly be a lab thing where you'll have a picture of the respiratory system and the arrow might be pointing to the trachea, for example, or the right or left lung, the diaphragm, an alveoli, a bronchiole, okay, an epiglottis. Okay, know the lobes of the lung, how many we have and all that. I'll get you started here with the right lung has 3 lobes. The left lung has 2 lobes and they're separated by a fissure. Okay. So know the structure and function, right? That's the same as saying the anatomy and the physiology. So the anatomy part and the physiology. So here's the structure. How does it work? Okay, so what is the function of the pyloric sphincter? Okay, sphincters are designed to contract, to not allow things to pass, and then they relax, which allows things to pass. So the pyloric sphincter allows for the chyme. Okay, chyme, the way, kind of an easy way of looking at chyme is you're going to take food, put it in a blender, turn on the blender liquefies the food. Okay, now that's chyme. That's what your stomach does. You know, you take your food, your hamburger and chicken and vegetables and all this stuff that's on the plate, and it's basically a big item. Okay, a hamburger is a big item. And then you're going to start to break it down, right? You take a bite and you have chemical and mechanical breakdown in the mouth. It's going to get into the stomach and continue with the chemical and mechanical breakdown. And when you keep doing that, eventually it liquefies. That's your chyme. The chyme is then gradually introduced into the duodenum, which is the first part of the small intestine. And what allows for that, the gatekeeper for that, is the pyloric sphincter. Okay, the gallbladder stores your bile. Okay, the stomach is a temporary reservoir for the food so that it can be turned into the chyme. The stomach has, it releases its own gastric juices to help you chemically break down the food that you've introduced. Okay, the small intestine is largely responsible for the actual assimilation of your nutrients. And then the large intestine is going to allow you to expel the waste as fecal matter, and it's also your body's, you can kind of look at it as your body's last attempt to retain water. So water is absorbed through the large intestine. So by the time that the fecal matter gets into the sigmoid colon rectum area, it's more solid and not liquid. Okay, it takes a lot of nerves and a lot of blood to break down food. So we have the nerve plexus in the stomach. So the myenteric, for example. So what does it do? Okay, what's its function? Okay, we talked about different digestive enzymes like amylase, for example. Okay, pepsin, your pancreatic enzymes. Okay, these are things that we like drew out together. So if you're doing your note cards, you would put like amylase on one side, and on the back, what does it do? Your lipase on one side, okay, your sucrase and all that. You know, what there's the enzyme and what's its function. Okay, so a hiatal hernia is where the stomach, the superior part of the stomach, starts to herniate through the diaphragm. Okay, the superior aspect of your stomach. So the esophagus, which is the food tube, goes from your mouth into the stomach, but it has to pierce the diaphragm in order to do that. Okay, so hiatal hernia is where that distal end of the esophagus and that first part of the stomach, where the esophagus connects to the stomach, is trying to herniate or push through the diaphragm. Okay, an inguinal hernia is down in the groin area or the hip flexor area, and the intestines try to work through the inguinal canal. Okay, that's an inguinal hernia. Okay, so we did look at like the common cystic duct and all that, the tubes that come out of the gallbladder and the liver and the pancreas, your pancreatic duct, and they enter into the duodenum. Okay, that is also part gross anatomy. So if there's an arrow pointing to a tube that is inside the pancreas that's clearly going into the duodenum, what is that? Right? So make sure you view those. Okay, what is your VLDLs, LDLs, and HDLs? Okay, well, first of all, very low density lipoprotein, and high density lipoprotein. Okay, we had a diagram that we drew of, you know, the liver is responsible for all this. Eventually, the LDLs are released from the liver, and with them, they carry cholesterol, which is deposited to the body. If there's excess cholesterol, your HDLs come in and collect all of that and bring it back to the liver. So that's why the HDL is known as the good cholesterol, because it picks up the excess cholesterol floating around in your body. Okay, know your digestive parts, like the accessory structures that go with them. So where is the liver, the gallbladder, the pancreas, the duodenum, the jejunum, the ileum, the the tongue? That's part of, the tongue's in the mouth, and it's part of chewing and breaking down your teeth, your molars, and your canine and your incisors and all that. They're designed to bite into and break down food. Okay, the esophagus. Okay, those are different digestive, the different parts to our body to help you move food, which is a bolus and eventually chyme throughout the body. Okay. So we do have different layers to the stomach. Okay, the most inside part to the stomach has a mucosal lining. You also find the rugae in there. And you have a muscle layer to the stomach that is going to help churn and tumble and mix up the bolus, which is your food, eventually into the chyme. Okay, what is the enteric plexus? What's the structure? What's its function? Okay, when you eat something, it goes into the mouth and eventually expelled. Okay, is fecal matter, and then what's the route that it takes from beginning to end? Okay, so be able to know the pathway of food from point A all the way to point B. Okay, structure and function of, so the body, the fundus, the cardiac region, the rugae, or the pylorus, the mucosa gastropits. Okay, these are all part of the stomach. Okay, we need the mucosa as a protective lining. Once you decrease your mucosal lining, you are at risk for gastrointestinal ulcerations. Okay, the rugae are folds within the stomach that help increase or decrease surface area, for that matter, depends on if the rugae folds have come out, which would decrease surface area, or if they recess into themselves, which would increase surface area. The cardiac region is the more superior region of the stomach where the esophagus comes into. Okay, we talked about different digestive enzymes that the stomach releases. Okay, different juices, if you will, that the stomach releases, like, for example, hydrochloric acid. Okay, hydrochloric acid and intrinsic factor come from the parietal cells in the stomach. Okay, let's see, another example would be your chief cells. Okay, they release the pepsin, and the pepsin eventually will help you digest your proteins. Okay, the order of the small intestine, duodenum, jejunum, ileum. Okay, the lobes of the liver. Okay, you have 4 of them. Okay, the right and left lobe, and then the caudate and quadrate lobe. Okay, blood gets into the liver. I mean, nutrients get into the liver because of blood flow. Okay, so everything in the body has to eventually pass through the liver Okay, and the liver does a lot of things, right? It's part of detoxing your body. It's part of being able to synthesize nutrients and all that you may need. It's part of storage. Okay, it can store stuff as a reservoir if you need it. Hepatocytes, which that's a fancy word for liver cells. Okay, they have a lot of functions. They're responsible for metabolism, detoxification, protein synthesis. Okay, so we talked about some of the hepatocytes in your notes. Okay, so know the gross anatomy of the bile duct, liver, gallbladder, pancreas. That seems like a repetitive question from something earlier from the gross anatomy. Pancreas, duodenum, okay, pancreatic duct, spleen. Okay, defined chyme. Okay, we mentioned that earlier. We used our blender analogy. Mastication is chewing. Then you have swallowing. Okay, what are Kupffer cells? Okay, well, those are the phagocytic cells that are in the liver. Okay, TMR, total metabolic rate versus basal metabolic rate. Okay, the one way you can look at your basal metabolic rate is if you were sleeping or in a coma, how much energy does it take to sustain life? You know, your own built-in cellular metabolism and the heart beating and, you know, respiration and all that stuff. You know, that requires energy. So that's your basal metabolic rate. Your total metabolic rate, which is your TMR, has to do with how active you are. Okay. So everybody has a BMR. If everybody's sleeping or if everyone is in a comatose state, everyone has to have some sort of energy to sustain the vital stuff. Okay, once you wake up and then you go about your day, everybody's different. Some people are sedentary, so their total metabolic rate would be not as much as a person who, let's say, trains for triathlons. Okay, that's a lot of energy they're expending. So you're dealing with two different TMRs. So it's your daily activities plus any exercise and anything like that you do is going to create your TMR. Okay, be able to do your caloric calculations, how many calories are in a carb, 1 gram of carb, 1 gram of protein, and 1 gram of fat. Okay, achlorohydria is the absence of hydrochloric acid. Okay, likely because the parietal cells are hurt. That can be from a side effect of medications. Could also be because of autoimmune, where the immune system is attacking and destroying the parietal cells. A peptic ulcer. Well, any kind of ulceration is basically an erosion of tissue, right? Well, a peptic ulcer is a stomach ulcer. These are found in the stomach. Okay, H. pylori, which is Helicobacter pylori, a bacteria, and an overgrowth of this can cause problems. Okay, you can test for this through a breath test or blood or stool. Okay, vitamin D3 is necessary. It's part of your fat-soluble vitamins. It's also very common for this to be deficient in people. And you can test to look at someone's vitamin D levels. Vitamin D levels values, or the units, is usually measured in nanograms per milliliter. Okay. In functional medicine, the optimal range is 50 to 80. From the Framingham study, they'll go as low as 30, and they suggest 30 to 50 nanograms per milliliter. But this is outdated because they came from the Framingham study. It's still being used today, but it's still considered outdated. And the more optimal range would be 50 to 80 nanograms per milliliter. Rhabdomyolosis, okay, is a condition where the muscles are breaking down, an abnormal breakdown of muscle tissue, and then it releases abnormal proteins into the blood. Okay, is that the myoglobins? And then that can damage the kidneys. Okay, your quick version of your renal system and your kidneys and all that, the quick version is it keeps the good stuff and gets rid of the bad stuff. So it is part of trying to keep your body as pure as possible. Okay, so too many toxins building up is not good. Okay, and your urinary system, you need fluid to expel the byproducts. So that's one reason why we urinate. If you are water or blood for that matter, and you're traveling through the kidney, what order of things are you traveling through as you enter into the kidney? Okay, so for example, you're going to enter in through the renal artery and eventually go into the nephron and eventually the Bowman's capsule, the renal corpuscle, and inside of that is the glomerulus. Okay, then you're going to travel through that to the proximal convoluted tubule, loop of Henle, distal convoluted tubule, collecting duct. Okay, the renal calyces, the renal pelvis, and then into the ureter, and eventually stored into the urinary bladder, and then eventually you will void. Okay. Now, all those parts have a function, like the function of the glomerulus and the podocytes. The podocytes are those, like the filter part. Your proximal convoluted tubule, loop of Henle, and distal convoluted tubule are a site where you're going to keep good stuff and get rid of bad stuff, and we drew all that out. So make sure you, for practice and just to burn it into memory, I would redraw that, right? The stuff that we did. Okay, like your hydrogens, for example, which is going to contribute to the pH of your body. Your body's going to get rid of that, get rid of some uric acid and ammonia and so forth. Okay, and you're going to keep amino acids and keep blood and keep some glucose. Okay, and then the things we talked about with normal versus abnormal urine analysis, you should not find blood in the urine, should not find proteins in the urine. Okay, what does it mean if you have urobilinogen that's found in the urine? What does it mean if you find white blood cells in the urine? Okay, stuff like that we went through with the UA.